You could literally lose up to 60% of your kidney function right now, like today, and feel absolutely nothing.
Yeah, zero symptoms.
Right. No pain, no noticeable fatigue, no weird changes in your daily routine. You could just walk right into your annual physical feeling like $1,000,000, get your routine blood work drawn, and the lab report could come back with this neatly printed normal range text right next to your kidney markers.
And that normal flag is completely hiding the fact that your renal system is actively failing.
Which is terrifying.
It really is. It is one of the most dangerous blind spots in modern medicine, honestly. We are so conditioned to think that biological failure is loud.
Right, like a heart attack or a broken bone.
Exactly. We expect alarms, acute pain, or some undeniable physical decline. But the kidneys are just, well, they're remarkably stoic organs.
They just suffer in silence.
We really do.
Yeah.
By the time they actually start sounding the alarm through physical symptoms, the structural damage is often totally irreversible and extensive.
Which is exactly why we are tearing apart the mechanics of that very specific diagnostic blind spot for this deep dive today. We are pulling heavily from a brilliant clinical brief published by iMedix, and it's titled The Creatinine Threshold: Navigating Stage 3 Kidney Disease.
Yeah, that's a great piece.
And for those who don't know, iMedix operates as this independent medical information platform, and their primary focus is really bridging the gap between raw, highly technical clinical data and, actionable patient safety.
Right, particularly regarding how kidney function dictates medication safety, which is a massive issue.
Huge issue. So our mission today is to decode the silent nature of kidney disease, explain why we measured this weird little molecule called creatinine, translate the math behind your eGFR, and completely debunk the terrifying misconceptions surrounding a stage 3 kidney disease diagnosis.
And we should probably state right at the top, our exploration today is strictly for educational and risk awareness purposes.
Yes, absolutely.
We're diving deep into the hemodynamics, the biomarker pharmacology, and the mathematical models used to assess kidney health. But, we're not prescribing treatments.
No internet diagnosing here.
Right, exactly. If the mechanisms we discussed today raise questions about your own metabolic panels, those require a direct contextual conversation with your nephrologist or your primary care physician.
Perfect. So we have an organ that degrades in complete silence and a diagnostic testing standard that routinely, literally routinely, misleads patients into a totally false sense of security.
Yeah, it happens every single day.
So to understand how that happens, we first have to understand the physical architecture of the kidney itself. If an organ is losing over half of its functional capacity without sending a single distress signal to the central nervous system, well, there has to be an extreme level of biological redundancy at play there.
The redundancy is staggering. A healthy human has 2 kidneys, right?
Right.
And within each of those kidneys are approximately 1 million microscopic filtering units.
1 million each.
Yes, per kidney. They are called nephrons. And these nephrons are responsible for processing about 180 liters of blood every single day.
That is an insane amount of fluid.
It really is. They are filtering out metabolic waste, balancing electrolytes down to the microosmolar level, and regulating your systemic blood pressure through this complex thing called the renin-angiotensin-aldosterone system.
Okay, so you have 2 million discrete filtration units. But if a disease process comes in and wipes out, say, 500,000 of those nephrons, why doesn't the overall filtration rate just drop by 25%?
That is the logical assumption, right?
Yeah. Why doesn't the system reflect the loss immediately?
Because of a localized hemodynamic adaptation that we call single nephron hyperfiltration.
Hyperfiltration. Okay, break that down for me.
Sure. When a significant portion of nephrons die off and become non-functional scar tissue, the remaining viable nephrons don't just maintain their baseline output, they step up.
They work harder.
Exactly. The afferent arterioles, which are the tiny blood vessels feeding into the surviving nephrons, they actually dilate.
So they open up wider.
Right. They allow more blood flow and increase the hydrostatic pressure within the individual capillary tufts, basically forcing each remaining nephron to filter significantly more blood than it was originally designed to handle.
Oh, wow. So it's essentially a structural engineering problem.
It really is.
It's like, imagine a massive suspension bridge, right, supported by 2 million steel cables. If a corrosive element slowly snaps half of those cables, the bridge doesn't immediately collapse into the river.
No, it stays up.
The remaining cables just take on the redistributed weight. So from a distance, the bridge looks totally fine. Traffic is still flowing. But internally, the remaining cables are operating way, way beyond their intended tensile strength.
That is a perfect biomechanical model for what is happening in your body. The overall output of the kidney, the total glomerular filtration rate, it remains deceptively normal because those surviving nephrons are carrying a massive redistributed load.
But I'm guessing they can't do that forever.
No, they can't. This hyperfiltration is a major double-edged sword. The increased hydrostatic pressure within those surviving capillary tufts, it actually causes physical shear stress on the endothelial cells and the podocytes.
Podocytes, what are those?
They are these specialized cells that wrap around the capillaries and give them structural support. So over time, that chronic high pressure causes the surviving nephrons to develop microfractures, they leak proteins, and eventually they undergo sclerosis.
Meaning they scar over.
Exactly. They scar over completely. So the compensatory mechanism itself actively accelerates the destruction of the remaining tissue.
Man. Which means relying on how you feel is effectively waiting for the last few steel cables to snap.
Yeah, by the time you feel it, the bridge is already falling.
Okay, so if the remaining nephrons are quietly working themselves to death, what are the primary corrosive forces snapping those cables in the first place? Because the iMedix paper highlights two massive systemic drivers, which they call the big two in nephrology.
Yeah, the big two are diabetes and hypertension. Together, they are responsible for the vast majority of chronic kidney disease globally.
Really? Just those two?
Mostly, yeah. And they destroy the renal architecture through distinct but often totally overlapping pathophysiological pathways.
Okay, let's start with diabetic nephropathy, because a lot of people intellectually connect diabetes to blood sugar and maybe to insulin resistance, but I don't think they necessarily understand the physical destruction occurring at the vascular level.
Right, they just think of it as a metabolic issue.
Yeah, so how does chronic hyperglycemia physically dismantle a nephron?
Well, it happens primarily through the formation of something called advanced glycation end products, or AGs.
TGGs, okay.
Yeah. When you have chronic, poorly controlled, elevated glucose in the bloodstream, those excess sugar molecules don't just float inertly, they are active.
They actually do things.
Yes. They undergo non-enzymatic reactions with circulating proteins and lipids, basically permanently binding to them. And these newly formed AGEs are highly reactive and deeply destructive.
So they start altering the structural matrix of the blood vessels themselves.
Precisely. As blood flows into the glomerulus, which is the highly pressurized porous capillary bed inside the nephron, these AGEs accumulate in the extracellular matrix.
Okay.
Specifically, they build up within the glomerular basement membrane. This membrane is the crucial physical filter that keeps large proteins in your blood while letting waste pass through into the urine.
So the AGs just get stuck there.
Sort of. They cross-link with the structural proteins of the membrane, like collagen. And this cross-linking forces the membrane to become drastically thickened, stiff, and paradoxically highly permeable.
Wait, so the filter gets physically thicker, but the holes in the filter actually get bigger and leakier?
Yes, exactly. The structural integrity is just completely ruined. Furthermore, the AGEs trigger a massive inflammatory cascade.
And of course they do.
Yeah, they bind to specific receptors on macrophages and endothelial cells, inducing oxidative stress and releasing pro-inflammatory cytokines. This toxic environment causes the podocytes, again, those crucial structural cells wrapping the capillaries, to undergo effacement.
Effacement meaning they just kind of melt away.
Yeah, they lose their intricate interlocking foot processes, detach from the membrane, and die. Once the podocytes are gone, the capillary essentially bursts and is replaced by non-functioning hyaline tissue.
Wow. So it's literally a microscopic breakdown of the architecture, driven by sugar physically binding to the infrastructure like some kind of biological sandpaper.
That is exactly what it is.
And then you have hypertension, which acts as a purely mechanical assault on those same delicate structures.
Yeah, hypertension is essentially barotrauma to the nephron. The glomerulus relies on a very precise, auto-regulated pressure gradient to function properly.
It needs a specific Goldilocks pressure.
Right. It needs high enough pressure to force waste across the membrane, but not so high that it damages the capillaries. When a patient has chronic, unmanaged systemic high blood pressure, the autoregulatory mechanisms of the kidney, which normally buffer the glomerulus from systemic pressure spikes, they eventually just fail.
So the blast doors give way.
Yep.
And that systemic force is transmitted directly into the microscopic capillary beds.
Exactly. The sheer stress of that high-pressure blood tearing through the delicate arterioles causes physical, mechanical damage to the endothelial lining.
And how does the body react to that?
Well, the body attempts to heal this mechanical damage by depositing smooth muscle cells and collagen into the vessel walls. This is a process called hyaline arteriolosclerosis.
So it thickens the walls to protect them?
It tries to, yeah. But as a result, the blood vessels become thick, rigid, and narrow, ultimately starving the glomerulus of oxygen of blood flow. The nephron essentially dies of ischemia.
So diabetes breaks down the structural integrity of the filter through glycation and inflammation, while hypertension physically bludgeons the capillaries with barotrauma and starves them of oxygen.
That sums it up perfectly.
But the iMedix framework also points out several other, more insidious causes of chronic kidney disease that can fly entirely under the radar, right? Like, even if you have perfect blood pressure and zero insulin resistance, you aren't completely safe.
No, unfortunately not. Glomerular diseases are a prime example of that.
What are those?
These are conditions that target the glomeruli independently of systemic metabolic issues. The most common ones are autoimmune in nature, such as IgA nephropathy or lupus nephritis.
Okay, so this is where the body's immune system essentially misidentifies the kidney as foreign tissue.
Correct. In IgA nephropathy, for instance, the body produces abnormally shaped immunoglobulin A antibodies. These abnormal antibodies complex together and physically lodge in the mesangium, which is the central stalk of the glomerulus.
They just get stuck in the filter.
Yeah. And the immune system detects these trapped complexes, assumes there is a major infection, and unleashes the complement cascade. It sends white blood cells and inflammatory mediators to attack the area, resulting in massive collateral damage to the surrounding healthy kidney tissue.
Oh man, friendly fire at the microscopic level.
Exactly. And then there are genetic factors. The paper specifically mentions inherited kidney conditions, which means you, as a listener, could be running ultramarathons, eating a pristine diet, and still be actively losing nephrons purely due to your DNA.
That is so unfair. What's the most common genetic one?
The most prevalent inherited condition is autosomal dominant polycystic kidney disease, or ADPKD.
Okay, polycystic. So cysts are forming.
Yes. This is caused by genetic mutations, typically in the PKD1 or PKD2 genes. These genes code for proteins involved in the function of primary cilia, which are the tiny antenna-like sensory organelles on the surface of your tubular cells.
Okay, so the antennas are broken.
Right. When these cilia are dysfunctional, it triggers a cascade involving cyclic AMP that causes the tubular cells to aggressively proliferate and secrete fluid, forming these massive cysts.
Wow.
And over decades, these fluid-filled cysts multiply and expand, physically crushing the adjacent healthy nephrons and replacing the functional renal tissue with massive, non-functional cystic tissue.
Which again just reinforces the terrifying reality that you cannot rely on physical symptoms or your perceived general health. You could be an elite athlete quietly growing massive cysts that are literally crushing your renal architecture.
Yes, you absolutely could.
But there's one more major cause outlined in the iMedix briefing, and I think this ties directly into their core mission of medication safety: medication-related kidney injury.
Right, this is a huge one.
Because we consume so many over-the-counter pharmaceuticals without a second thought, how much damage are we actually doing with just, a handful of ibuprofen?
The pharmacokinetics of over-the-counter pain relievers, specifically non-steroidal anti-inflammatory drugs, or NSAIDs, are deeply problematic for renal hemodynamics when used chronically or, frankly, just in the wrong context.
Wait, really? Even just Advil or Motrin?
Yes. NSAIDs, like ibuprofen or naproxen, they work by inhibiting the cyclooxygenase enzymes, KOX1 and KOX2. These enzymes are necessary for the body to synthesize prostaglandins, which are lipid compounds that drive inflammation and pain.
Okay, so you block the enzyme, you stop the prostaglandins, the inflammation drops, and your sprained ankle stops hurting. I mean, it seems like a clean biological transaction.
It is clean for the ankle, but it is potentially disastrous for the kidney, especially a kidney that is already under stress.
Why? What did the prostaglandins do in the kidney?
In the renal system, prostaglandins are not just inflammatory mediators, they are critical vasodilators.
Oh, they keep the blood vessels open.
Exactly. The kidney uses vasodilatory prostaglandins to keep the efferent arteriole wide open, ensuring adequate blood flow into the glomerulus. This is especially vital if the body is slightly volume depleted.
So, like, if you are dehydrated from a virus, or maybe you've been working outside in the heat?
Yes. If you are dehydrated, your blood volume is low, and your systemic blood pressure might be dropping. The kidney relies on those specific prostaglandins to forcefully hold the intake valve open, ensuring the nephron still gets enough blood to survive despite the low systemic pressure.
Oh, I see where this is going.
Right. Now, introduce a high dose of ibuprofen into that dehydrated environment. The NSAID completely shuts down prostaglandin synthesis everywhere, including the kidney.
So the intake valve, the afferent arteriole, it loses its vasodilatory support.
And it clamps down hard.
Yeah.
Blood flow to the glomerulus plummets, the filtration rate crashes, and the nephron suffers acute ischemic injury because it is literally being starved of oxygenated blood.
Wow.
This is exactly why nephrologists are incredibly aggressive about limiting NSAID exposure, particularly in patients who already have compromised renal function or who are taking blood pressure medications that alter these same hemodynamic pathways.
That makes total sense. So we have this silent organ possessing a massive functional reserve, capable of masking severe structural degradation from diabetes, hypertension, autoimmune crossfire, genetic cysts, and pharmaceutical ischemia.
It's dealing with a lot.
It really is. And the physical symptoms just won't save us in time. The only way we can actually monitor the structural integrity of those 2 million nephrons is through the biochemical exhaust they leave behind in the bloodstream.
Right, the lab tests.
Which brings us to the diagnostic pivot of this entire discussion, the biomarker that every single listener has seen on their comprehensive metabolic panel, the one that routinely lulls patients and even some clinicians into a totally false sense of security. Creatinine.
Creatinine. It is the
Yeah.
cornerstone of modern renal diagnostics, yet, ironically, its biological origins have absolutely nothing to do with the kidneys themselves.
Wait, really? Nothing at all.
Nothing. It is entirely a metabolic byproduct of skeletal muscle.
Okay, so it's just cellular exhaust from our muscles. Let's trace the pathway of this molecule. Where does it actually start before it ends up in the blood?
Well, it begins with a compound called creatine, which is synthesized primarily in the liver and then transported to your skeletal muscles.
Okay.
Inside the muscle tissue, it is phosphorylated into phosphocreatine, which serves as a rapidly mobilizable reserve of high-energy phosphates in skeletal muscle and in the myocardium, the heart muscle.
Right, so when your muscles contract, whether you are sprinting, lifting a heavy box, or even just sitting up straight and maintaining your posture, they are consuming that energy.
Yes, the ATP cycle. And as part of that normal baseline metabolic turnover, phosphocreatine spontaneously and non-enzymatically degrades into creatinine.
Does it happen randomly or is it steady?
It happens at a highly predictable rate of about 1 to 2% per day. This creatinine diffuses out of the muscle cells, enters the systemic circulation, and just floats freely in the blood plasma.
And because it is a relatively small molecule, it flows straight into the glomerulus.
It flows into the glomerulus, it is freely filtered by the nephrons, and it is excreted in the urine. Crucially, the kidneys do not reabsorb creatinine, and under normal conditions, they secrete only a very small amount of it.
So it's a direct one-way street out of the body.
Exactly. Therefore, the rate at which creatinine is cleared from the blood is an excellent proxy for the overall glomerular filtration rate. If the filtration plants are running at full capacity, the level of creatinine exhaust accumulating in the blood remains very low and steady.
But if the filtration plants start taking damage and going offline, the exhaust backs up.
Yes, and the serum creatinine concentration in your blood rises.
I mean, the logic seems completely airtight. Less filtration equals more creatinine in the blood. So if I get my lab results and my serum creatinine is 1.0 milligrams per deciliter, and the lab report prints a reference range of 0.8 to 1.2 next to it, indicating my result falls perfectly in the middle, why does the iMedix brief explicitly warn against trusting that normal flag?
Because that flag is incredibly misleading in isolation.
But if the lab flags it as normal based on massive population data sets, shouldn't standard deviation account for the vast majority of patients?
Standard deviation accounts for a population, yes, but it does absolutely nothing for the individual pharmacokinetic reality of the patient sitting in the exam room.
I'm not following.
The fundamental flaw of raw serum creatinine is that its production is completely dictated by total body muscle mass. The lab's reference range assumes an average amount of muscle mass, but patients are rarely average.
Oh. So the raw number is highly volatile based on who you are. If the denominator is kidney function, the numerator is just how much skeletal muscle you happen to carry on your frame.
Exactly. Let's look at a clinical extreme to illustrate why that reference range is so dangerous. Imagine a 25-year-old competitive bodybuilder.
Okay, picture him.
He weighs 240 pounds, almost entirely dense skeletal muscle. He consumes a high-protein diet and supplements with exogenous creatine monohydrate to maximize his phosphocreatine stores.
He's huge.
Right, because he has a massive amount of muscle mass. His baseline generation of creatinine is enormous. Even with perfectly healthy, highly functioning kidneys, his baseline serum creatinine might routinely sit at 1.4 or 1.5 milligrams per deciliter.
Which would trigger a red abnormal flag on his lab report.
Yes, potentially sending a perfectly healthy person into a diagnostic panic about kidney failure.
Wow. Okay, now flip it.
Look at the exact opposite end of the spectrum. Consider an 85-year-old woman suffering from severe sarcopenia, which is the age-related loss of skeletal muscle mass and function.
Mm.
She weighs 90 pounds. Her muscle mass is minimal, meaning her daily generation of creatinine is incredibly low. When her kidneys were healthy, her baseline serum creatinine might have been a mere zero point 0.4 milligrams per deciliter.
Because she has a tiny engine, she produces a tiny amount of exhaust.
Correct. Now, suppose she develops advanced chronic kidney disease. She loses 60% of her renal function. The filtration rate plummets. Her creatinine exhaust backs up, doubling and then almost tripling in her bloodstream, rising from 0.4 all the way up to 1.1 milligrams per deciliter.
Wait, but 1.1 falls squarely within that standard 0.8 to 1.2 normal reference range?
Yes. The lab report will print it in black ink. No red flags, no alerts. The physician reviewing a stack of 50 lab reports at the end of the day might just scan for red flags, see the normal creatinine, and move right on.
That is insane. Meanwhile, this woman has lost more than half her kidney function, she is in advanced renal decline, and the raw creatinine number actively camouflaged the disease just because her lack of muscle mass artificially deflated the serum concentration.
That is the definition of a diagnostic trap. The raw number is completely untethered from reality unless you factor in the physical composition of the patient.
And I'm guessing it isn't just extreme outliers like bodybuilders and frail octogenarians. There have to be highly dynamic variables that shift this raw number around day to day.
Absolutely. Hydration status profoundly alters the volume of distribution.
Like just how much water you drink.
Exactly. If you are severely dehydrated on the day of your blood draw, your total plasma volume is reduced. The absolute amount of creatinine in your system hasn't changed, but it is now dissolved in a much smaller volume of fluid, meaning the concentration spikes.
So you get an artificially elevated reading just from being thirsty.
Yes. Conversely, if you aggressively overhydrate before the test, you dilute the plasma, artificially suppressing the raw creatinine number.
What about the laboratory assays themselves? We always assume a blood test is a universal truth. But is a 1.0 measured at a rural clinic the exact same chemical measurement as a 1.0 at a massive research hospital?
Not necessarily. Historically, creatinine was measured using something called the Jaffer reaction.
The Jaffe reaction?
Yeah, it's a colorimetric assay developed all the way back in the late 1800s. It involves mixing serum with alkaline picrate, which turns orange-red in the presence of creatinine.
Okay, sounds simple enough.
It is, but the problem is the Jaffe reaction is notoriously nonspecific. It cross-reacts with other compounds in the blood, like glucose, bilirubin, and certain proteins, which we call non-creatinine chromogens.
Meaning it changes color for things that aren't creatinine.
Exactly. This cross-reactivity can artificially inflate the true creatinine value by up to 20%.
A 20% margin of error built directly into the chemical test itself.
Yes. Now, modern laboratories have largely transitioned to enzymatic assays, which use a cascade of specific enzymes to isolate and measure creatinine much more accurately, with far less interference from other metabolites.
It's good, at least.
It is. However, because different labs use different assay methodologies and different calibration standards, comparing a raw creatinine value from lab A to lab B still introduces significant statistical noise.
So to summarize the diagnostic nightmare of raw creatinine, its generation is completely dependent on muscle mass, which varies wildly by age, sex, and physical conditioning. Its concentration is skewed by daily hydration levels, and its actual chemical measurement can be distorted by the assay technology used at the laboratory.
It is a highly volatile, incredibly noisy signal.
How on earth do nephrologists actually make a concrete diagnosis if the foundational metric is this flawed? There has to be a way to filter out the noise and find the true signal.
Well, the medical community realized decades ago that relying on raw serum creatinine was totally inadequate. They needed a mathematical translator,
A translator.
a way to correct for the variables of muscle generation and isolate the true filtration capacity of the kidney. That translator is the eGFR, the estimated glomerular filtration rate.
I think it's totally vital to point out the explicit use of the word estimated in that acronym. The medical community isn't claiming this is a perfect, direct physical measurement. It is an algorithmic estimation.
That distinction is absolutely crucial for patient understanding. To find the true exact glomerular filtration rate, we would have to measure the renal clearance of an exogenous substance that is freely filtered by the glomerulus, but neither secreted nor reabsorbed by the renal tubules.
Which would be hard to find naturally in the body.
Right. The gold standard for this is actually a continuous intravenous infusion of a fructose polymer called inulin.
Wait, so that requires injecting a foreign carbohydrate into the patient, placing a urinary catheter, and taking timed blood and urine samples over several hours.
Yes, it is invasive, expensive, and entirely impractical for routine clinical use.
Yeah, I'm not doing that at my annual physical.
Nobody is.
Hmm.
So researchers developed complex statistical equations derived from massive population studies to estimate that true clearance rate using only the readily available serum creatinine. Over the years, these equations evolved. We moved from the Cockcroft-Gault equation in the 1970s, which actually incorporated the patient's actual body weight, to the MDRD equation in 1999, which improved accuracy in patients with established kidney disease.
But the iMedix framework and modern clinical guidelines, they rely on the most recent iteration of this math, correct?
Yes, they use the CKD EPI equation, which was developed in 2009 and updated in 2021.
And how does that one work?
This equation takes the raw, noisy serum creatinine number and applies demographic variables as mathematical surrogates for muscle mass. It factors in the patient's exact age, because we know muscle mass naturally declines with age.
Right.
It also factors in biological sex, accounting for the physiological baseline differences in skeletal muscle density between males and females.
So by plugging the age and sex into the formula, the algorithm essentially predicts the size of the patient's engine, their baseline creatinine generation, and mathematically strips that noise out of the serum concentration.
Precisely. And the output of that equation is a normalized metric, milliliters per minute per 1.73 square meters of body surface area.
That's a mouthful, but it normalizes the result, so a nephrologist can accurately compare the renal function of a tiny, frail 85-year-old directly against the function of a massive 25-year-old bodybuilder.
Exactly, which fundamentally shifts the diagnostic paradigm. The iMedix paper heavily emphasizes the creatinine threshold when diagnosing stage 3 kidney disease. But based on this advanced pharmacology, the threshold isn't a fixed raw creatinine number at all.
Right. A creatinine of 1.3 might mean stage 4 failure in the elderly woman, while the exact same 1.3 means perfectly healthy stage 1 function in the muscular athlete.
The eGFR is the ultimate clinical arbiter. It provides the standardized context. When a clinician formally stages chronic kidney disease, they are categorizing disease based exclusively on the calculated eGFR, not the raw creatinine value.
And that leads us to the psychological heavy lifting of this deep dive, navigating the clinical reality of a stage 3 diagnosis.
This is where a lot of patients really struggle.
Because the moment a patient logs into their portal, sees an eGFR of 55, and reads the words stage 3 chronic kidney disease, the anxiety is instantaneous and overwhelming.
Oh, absolutely.
Culturally, we map the staging of kidney disease onto our understanding of oncology. We hear stage 3 cancer, and we know that implies systemic spread and poor prognosis. When a patient hears stage 3 kidney disease, they immediately visualize an imminent crash. They picture dialysis machines, transplant lists, and terminal decline.
And it is a profound failure of medical communication that this misconception is so pervasive. The nomenclature of CKD staging induces unnecessary panic. Stage 3 chronic kidney disease is not end-stage renal disease. It is not imminent failure.
So where is it?
It's precisely in the middle of a 5-stage spectrum.
Let's clearly define that spectrum to alleviate the panic for you guys listening. Where does stage 3 actually sit relative to baseline function and end-stage failure?
Well, stage 1 CKD indicates evidence of kidney damage, perhaps protein in the urine, but a normal eGFR of 90 or higher.
Okay, so that's the top end.
Right. Stage 5 CKD is true renal failure, defined by an eGFR of less than 15, which is the threshold where renal replacement therapy, like dialysis or transplantation, typically becomes necessary to sustain life.
And stage 3?
Stage 3 sits in the exact center, encompassing an eGFR range from 30 to 59. This represents a moderate reduction in functional nephron mass.
So they are still working.
The kidneys are absolutely still functioning. They're still regulating electrolytes, still clearing toxins, and still managing fluid balance. They're simply operating with a reduced workforce.
Right, going back to the analogy, the suspension bridge has lost some cables, but the bridge is absolutely still standing and carrying traffic.
That reframing is incredibly important.
But the iMedix clinical framework goes much deeper than just stage 3. It heavily emphasizes the vital clinical distinction between stage 3A and stage 3B.
Yes, that split is critical.
If stage 3 is the middle ground, why does the medical community rigidly divide it in half? Does a drop of a few eGFR points really alter the physiological reality of the patient that dramatically?
The distinction between 3A and 3B is arguably the most critical transition point in all of nephrology.
Really?
Yes, it represents the tipping point where the silence of the disease breaks and systemic complications begin to rapidly compound.
Okay, break that down for me.
Stage 3A is defined by an eGFR between 45 and 59. Clinically, this is mild to moderate loss of function. For the vast majority of patients in stage 3A, the compensatory mechanisms, that single nephron hyperfiltration we discussed, they're still highly effective at masking the deficit. Patients are generally asymptomatic.
So the remaining nephrons are handling the extra load without triggering any systemic alarms.
Exactly. But stage 3B, defined by an eGFR between 30 and 44, represents moderate to severe loss of function. This is the hemodynamic breaking point.
The hyperfiltration mechanism reaches its absolute limit.
And it begins to fail. As the filtration rate drops into the 30s, the body can no longer maintain homeostatic balance.
This is when the silent engine finally starts making noise. What are the physiological manifestations of hitting that 3B threshold?
You start seeing a cascade of systemic disruptions. The kidneys can no longer efficiently excrete phosphorus, leading to hyperphosphatemia.
Too much phosphorus in the blood.
Right. Which in turn triggers the parathyroid glands to pull calcium out of your bones, causing renal osteodystrophy.
Oh, wow. So it literally weakens your bones.
Yes. Also, the failing kidneys reduce their production of erythropoietin, which is the hormone that signals the bone marrow to make red blood cells,
So you become anemic.
leading to profound anemia and severe fatigue. You see fluid retention manifesting as peripheral edema, and the buildup of uremic toxins can cause neurological symptoms like brain fog and altered taste.
So the structural failure finally cascades into systemic, hormonal, and metabolic failure.
It does. But beyond the physiological symptoms, the iMedix framework centers on a much more acute danger that materializes in stage 3B, and it circles back to medication safety.
Right. How does an eGFR in the 30s alter the pharmacokinetics of the drugs a patient is taking?
Well, as the glomerular filtration rate declines, the renal clearance of medications plummets. If a drug is primarily excreted by the kidneys, a drop from an eGFR of 60 down to 35 fundamentally alters the drug's half-life in the plasma. The area under the curve, the total systemic exposure to the drug, it expands massively.
Because the biological exhaust fans are broken, the drug just continues to circulate and recirculate.
Precisely. Let's look at metformin, which is one of the most common first-line medications for type 2 diabetes. Metformin is cleared entirely by the kidneys.
Entirely.
Yes. In a patient with healthy renal function, it is safe and highly effective. But if that patient progresses to stage 3B CKD and continues taking their standard dose, the metformin begins to accumulate to toxic levels.
Because it can't get out.
Right. And this toxic accumulation can trigger a rare but incredibly dangerous metabolic complication called lactic acidosis, which carries a very high mortality rate.
Oh my God. So the very drug prescribed to manage the diabetes, which is likely the root cause of the kidney disease in the first place, becomes a lethal toxin because the kidney can no longer excrete it. That is a terrifying feedback loop.
It is, which is why aggressive medication reconciliation is the absolute cornerstone of managing stage 3B. And it's not just metformin.
What else?
Direct oral anticoagulants, or DOACs, used for atrial fibrillation, they require strict dose reductions as eGFR falls. Otherwise, the patient is at massive risk for spontaneous, catastrophic hemorrhaging.
Wow.
Common renally cleared antibiotics, antivirals, and neurological drugs like gabapentin all require precise dosage adjustments. If a patient with an eGFR of 32 takes a standard dose of gabapentin, they may experience profound central nervous system depression or even coma simply because the drug's half-life extended from 6 hours to 36 hours.
Which perfectly illuminates the mission of the iMedix brief. Knowing your eGFR isn't just about tracking a disease state. It is an active, required parameter for safely dosing almost every chemical you put into your body.
It is a critical metric for daily safety.
But this brings up the most common, visceral question patients have when they are confronted with this diagnosis. If I am sitting in the clinic and I understand the pharmacokinetics and I understand the structural damage of stage 3B, I am going to look at the nephrologist and ask, how do we reverse this? What is the therapeutic protocol to regrow the nephrons, heal the glomeruli, and get my eGFR back up to 90?
It is the most natural human reaction to a medical diagnosis. We
Yeah.
expect a curative paradigm.
Right, fix it.
But the clinical reality of chronic kidney disease requires a fundamental reframing of what success actually looks like. Once the glomerulus undergoes sclerosis, once that intricate capillary bed and the podocytes are replaced by dense, non-functional scar tissue, it cannot be regenerated.
It's gone.
It is gone. The human kidney does not possess the capacity to synthesize new nephrons after birth. The structural loss is permanent.
So you cannot unsnap the cables on the suspension bridge. If a cure is biologically impossible, what is the actual clinical objective when treating stage 3?
The clinical objective is aggressive, unyielding stabilization. The goal is to build a pharmacological and metabolic fortress around the remaining viable nephrons to ensure they survive for the remaining duration of the patient's life.
So we shift from a curative mindset to a preservation mindset.
Exactly.
But how do we actually build that fortress? How do we alleviate the stress on the surviving nephrons to stop the hyperfiltration cascade?
We systematically target the primary drivers of hemodynamic stress we discussed at the beginning. If the patient has diabetic nephropathy, we deploy advanced therapeutics like SGLT2 inhibitors.
And what do those do?
These drugs not only improve glycemic control, but they act directly on the renal hemodynamics, altering the tubulo-glomerular feedback mechanism to physically constrict the afferent arteriole, effectively turning down the high-pressure flow into the glomerulus and reducing the hyperfiltration stress.
Oh, I see. You essentially install a pressure regulator on the intake valve to protect the fragile capillaries.
Exactly. And if hypertension is driving the damage, we utilize ACE inhibitors, or angiotensin receptor blockers. These specific antihypertensives preferentially dilate the afferent arteriole, which is the exit valve of the nephron.
So by opening the exit valve, we immediately vent the hydrostatic pressure out of the glomerulus, halting the barotrauma and reducing protein leakage.
Yes. We rigorously adjust every single medication to prevent toxic accumulation. We optimize systemic blood pressure to tight targets.
It's a comprehensive defense strategy.
It is. And if a patient is diagnosed with stage 3B CKD at age 60, and through aggressive pharmacological management and dietary modification, they stabilize their eGFR at 38 for the next 25 years, they will never reach end-stage renal disease.
Really?
They will never require dialysis. They will die of old age with functionally adequate, albeit reduced, kidneys. In the realm of nephrology, that stabilization is not a failure to cure. It is a massive, life-altering clinical victory.
Stabilization is the victory. Defending the territory you still hold, rather than agonizing over the territory you've lost. That reframing really transforms a stage 3 diagnosis from an impending death sentence into an actionable, manageable, chronic condition.
That's exactly how it should be viewed.
So let's synthesize the immense ground we've covered today. We started by exploring the deceptive, silent nature of the renal architecture, how the massive built-in redundancy of 2 million nephrons allows the kidneys to mask severe structural degradation through single nephron hyperfiltration, essentially working the surviving tissues to the point of microfracture and scarring.
Right. And we examine how systemic metabolic failures like diabetes break down the structural matrix of the filters through advanced glycation end products, while hypertension mechanically destroys the capillaries through sustained barotrauma.
And we highlighted how even everyday medications like NSAIDs can induce acute ischemic injury by altering the delicate vasodilatory pathways of the nephron.
And then we deconstructed the diagnostic illusion of raw serum creatinine.
Yes, we proved that relying on a static normal range is fundamentally dangerous because creatinine generation is entirely dictated by skeletal muscle mass. A raw number of 1.2 could signify peak athletic health in one patient and advanced, life-threatening renal failure in another, masked by the sarcopenia of old age.
Which necessitated the mathematical translation of the eGFR, an algorithmic estimation that utilizes demographic surrogates to strip away the noise of muscle mass and isolate the true hemodynamic capacity of the kidney, providing the standardized metric required to accurately stage the disease.
And finally, we dismantled the psychological terror of a stage 3 diagnosis, clarifying the critical pharmacokinetic divergence between stage 3A and stage 3B, and establishing that the ultimate clinical goal is not the impossible regeneration of dead scar tissue, but the aggressive pharmacological defense of the surviving nephrons.
As we conclude, I really encourage everyone listening to apply this framework the next time they review their metabolic panel. The data provided by resources like iMedix is designed to elevate patient health literacy.
Tell
Understanding the mechanics of your eGFR and why your physician might critically alter your medication dosages based on that specific number, it transforms you from a passive recipient of a diagnosis into an active, informed participant in your own renal preservation.
Knowledge is the ultimate diagnostic tool. And as we wrap up, I want to leave you with one final fascinating avenue of scientific inquiry. We spent this entire discussion dissecting the inherent flaws of creatinine, right? A biomarker so hopelessly tethers the variable noise of skeletal muscle mass that we had to invent complex, population-derived statistical algorithms just to guess at the actual filtration rate of the kidney.
It's a lot of hoops to jump through.
It is. But what if we could bypass that noise entirely? What if we're on the precipice of abandoning creatinine altogether? Researchers are increasingly focused on a different molecule circulating in your blood right now called cystatin C.
Cystatin C.
Unlike creatinine, cystatin C is a low molecular weight protein produced continuously by virtually every single nucleated cell in the human body. Its production rate is remarkably constant. It's completely independent of muscle.
Exactly. It does not care if you are an 85-year-old frail grandmother, a 25-year-old bodybuilder, male, female, heavily hydrated, or completely dehydrated. It is freely filtered by the glomerulus and completely broken down by the renal tubules. So if we have a perfect, steady-state molecule that completely ignores the chaotic variables of muscle mass and diet, a molecule that provides a crystal-clear direct window into the actual hemodynamic function of the nephron, why aren't we using it for every single patient, every single time?
That's a great question.
What are the economic and structural barriers keeping this a superior biomarker out of the standard metabolic panel, and how quickly will those barriers fall? It is a tantalizing glimpse into the near future of diagnostic medicine, and a question worth asking the next time you step into the clinic. Thanks for joining us, and we will see you on the next Deep Dive.